Welcome to the Heart of Innovation, 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global P.A.D. Association at PADHelp.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global P.A.D. Association, Kym McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone, and welcome to the show. Dr. Phillips is off saving some limbs, duty calls. So Dr. Nik Patel with AVA Vascular in Murrieta and Vista, California, is pinch hitting his guest host today for a very special presentation and discussion where we are honoring a very special individual who eats, sleeps, and breathes saving life and limb for people with a disease more prevalent and deadlier than most cancers combined, known as Peripheral Artery Disease, or P.A.D., which is blocked arteries in mainly the legs that cause leg cramps, leg pain, and leg fatigue. He is so dedicated to improving patient outcomes that if he can't do it with the tools and techniques that are available, he invents them. That's why we are honoring today Dr. James Joye with Golden State Heart and Vascular in the San Francisco Bay Area in California through the Global P.A.D. Association's 2024 P.A.D. Impact Awards with the Champion of Innovation Award. And we're going to introduce you to him in just a moment and tell you about a new FDA-approved procedure that he invented that is actually increasing a physician's ability to restore blood flow to the legs and prevent amputation. But first, I'd like to give a big hello to my co-host for the day, Dr. Nik Patel. Hi, Nik.
Thank you, Kym. Honored to be here and honored to be with Dr. Joye as well and the guest audience. It's been a busy week and busy weekend now. So, things have been really great. Been really helping a lot of people with critical limb ischemia, healing wounds, and glad to be part of this community. And
Any case that stands out this week? I mean, it's a tough week for you as a CLI fighter, critical limb ischemia. That's the most advanced stage of PAD, and we call doctors like you and also Dr. Joye CLI fighters.
Yes, absolutely. It's always, we're always learning new things from patients and challenging procedures with the challenging disease. Definitely we'll share some experiences as the show goes on.
Yeah, but first, I think before we get started, how about a moment of inspiration?
Absolutely. I have a good quote from one of my favorite movies, The Shawshank Redemption. It's
Oh,
a
yeah.
1994 movie. And the quote is Tim Robbins, who's the leading actor with Morgan Freeman. He talks about hope. And he says, hope is a good thing and maybe the best of things, and no good thing ever dies. So I want everybody out there to keep their hopes up, and we'll get through this fight. And hope is very important. So keep that in mind.
One of my biggest pet peeves is when a doctor tells me you really should not give false hope to people. And I said, it's not about giving false hope, it's giving hope. And hope helps you feel good. Hope helps you to literally just be compliant. It helps you to move forward. I think everyone deserves even a glimpse of hope, no matter what their diagnosis, because doctors like you and doctors like Joye give so many hope because you've proven that you can make the impossible possible. What some doctors say is impossible, you actually make possible. And that's amazing. I love that quote.
Thank you.
So I want to introduce you to another hope giver here in the world of limb salvage, Dr. Jim Joye. He is the Global PAD Association's Champion of Vascular Innovation for 2024. Now, this award, before we introduce him, it honors an individual who exemplifies exceptional advocacy for PAD patients, standing up for their rights and well-being, even at personal and professional expense. This champion will have made significant contributions to community building, awareness raising, and the fight against healthcare disparities. So important, all while demonstrating personal sacrifice and a measurable impact on the P.A.D. patient community. Now, most importantly, for this particular award, this individual has made a significant impact on improving care through innovation. And because his patients this year have asked the most about a new minimally invasive bypass, we had to honor Dr. Jim Joye for that contribution and more to improving P.A.D. care. He invented a device known as P.TAB, and we're going to hear more about that over the next hour. But first, let's offer a warm welcome and congratulations to Dr. Jim Joye, Champion of Vascular Innovation for 2024. So well deserved, Dr. Joye.
Very kind of you, Kym. Yeah, I'm as is usual in a situation like this. I'm standing in front of countless people that made this happen, that helped to bring this concept to reality and ultimately get it to market. So I'm honored, I'm humbled, and I'm grateful for everybody that contributed to make this happen.
You know, so many doctors out there today, especially when it comes to limb salvage, are continuing to argue for their own limitations, saying things, can't be done, they shouldn't be done. Let's just amputate the legs because there's no procedure out there. There's no evidence for any procedure that makes it worth our while to restore blood flow to these patients. So let's just not delay the inevitable. Let's just go ahead and amputate. And I always say to them, well, you know what? Why not create the evidence? Why not help create the solutions? And here you are, creating a solution. What is it about your training, who you are with your character, that makes you not argue for your own limitations and truly live up to the practice of medicine?
Yeah, I just think at the end of the day, it has to be a very individualized approach to each patient. And there's nothing more irrevocable than an amputation. And I think for me and for others that do this type of work, you always want to help. You always want to offer some, as you mentioned, hope, some pathway forward. And a lot of times that drives innovation. And so in this situation, we're facing some of the most difficult lesions that we come across in the lower extremities. We didn't have a good solution. And now we have something really significant we can offer.
And coming up right here on the Heart of Innovation, we're going to hear the significant impact that he is having with this brand new device that he is the brainchild of. So don't go away, right here on KDOW in the Heart of Innovation.
I can think of patients where I've tried and failed to try to revascularize arteries because there's nothing there to revascularize into. And then, down the road after 3 attempts, switch to arterializing the vein, lymph flow or DVA, deep vein arterialization, is a technique to, when you don't have any distal end flow arterially to the tips of the toes, you're basically arterializing a vein in the leg that's already there. To allow perfusion of that extremity. It's a last resort, but it allows you to bring blood to a territory where you don't have options otherwise. And so, it's not a technique that I came up with, but just those kinds of thinking outside the box by pioneers within the space is what keeps moving the needle forward in having options for patients to really find a way when there seems to be no way.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everyone. This is Dr. Nik Patel. I'm filling in for Dr. Phillips while he's saving some legs and some lives. We have a very important and a famous guest on the show today, Dr. Joye, who's an inventor of a new device that can be utilized in patients saving legs without a knife, without an incision. So let's get to the show, and let's have Dr. Joye tell us more about the invention and how what inspired him. Dr. Joye, was there a patient that you came across that led to you thinking, saying, hey, I need to do something differently. I need to see what's available out there, and you looked around and you didn't find anything, and you said, let me try this. And was it a patient scenario, or was it just the idea that came to your mind that led to this invention?
Yeah, great question. So I think any of these processes, there's a number of kernels along the way that really make the final boom happen. I started doing long segment occlusion work back in the early 90s. And at the time, we had just discovered some newer techniques to get through these long blockages without opening the patient's leg up. We had some really prehistoric stents that we were using to, make this beautiful result when we finished. But the reality was, and this is a reality, unfortunately, that's persisted despite stent generations of development since, that these long segment stents just continue to close. And we're tasked with reopening, and it's just it's a kind of a fruitless venture. And then a number of years later, I was involved in a different technology as an advisor, and I was kind of the junior guy in the room, kind of the guy they sat in the corner, and we were trying to invent a way to do coronary artery bypass surgery without surgery. And this was a technique that failed miserably. It just couldn't be done. But the idea behind it sparked in my mind, why are we wasting our time trying to do this in the coronary arteries when we have this large format, big problem in the lower extremities that we could easily apply it to? And at the time, there was, nobody was really interested in that because, the heart was where where the excitement was. And, I was a cardiologist that was spending more and more of my time in the vascular world. And I said, you know what, I'm just going to do this on my own. And, if they don't want to pursue it, great. I'll just see where it takes me.
So how did you even get started with it? So you're a doctor, you have an idea. What does it mean for you to go to the drawing board?
Yeah, literally started on the drawing board, Kym. Lab notebook, lots of pictures of anatomy. I'm drawing, asking a lot of my colleagues questions about what they encounter in open surgery, looking at the equipment that was on the wall, things that were already commercially available. How could I modify these to do what I wanted to do? And then it went through everything from cadavers to animals to, lots of engineering apparatus, models, so on and so forth. And over the course of time, just refined and refined and refined. And here we are.
It always starts with these off-the-shelf items. And I'm curious what your off-the-shelf looked like and what tools were involved in your makeshift model before it became the actual PTAB or Detour bypass system that was, in the box.
Yeah, in the box at the time was pretty meager. We had stents, we had stent grafts, we had catheters, we had wires, we had all those things, but we didn't have the tools that were necessary to release on the public physician and say, all right, here's a kit, go and do this. And so I did probably 50 plus patients with this kind of MacGyvered approach. And I'm sure that the cath lab staff, if they were on the line, would say that it was painful because they were long procedures. It required a lot of calisthenics. Patients were being flipped from their stomach to their back to this and the other thing. We had to come at it from both different directions. It just was not a toolkit available. But from kind of trudging through that and suffering through those limitations, that's where the sparks came that said, all right, what if we had a device that did this? What if we had a device that did that? How do we need to redesign a stent graft so that it has the proper strength and flexibility and so on and so forth to deliver the blood to the target downstream?
So how does the PTAB, so it's called PTAB.
Yeah.
So talk about how you went from this makeshift model to a system, the Detour bypass system in the box, and you got through the FDA process. Talk about what it is and how it works.
Yeah, we used to call it PQ bypass. That was the original company. PQ was just a cute play on words for percutaneous. PTAB is a bit of a mouthful. It's Percutaneous Transluminal Arterial Bypass, so hence PTAB. I've been working on this in one form or another for 20 years, either conceptually, in cadavers, in animals, etc. I have had a very unusual tourism of the medical globe. We've worked in everywhere from New Zealand to Germany to Latvia to Poland to, you name the country. We did a lot of testing outside of the United States to refine it and prove to the FDA that, when we came to them with a clinical trial, it was going to be worth doing. And what we've done in this procedure is basically taken advantage of our God-given anatomy. So in the lower extremities and throughout the body, there are arteries that are right next to the veins. And in the case of the leg, there's a huge femoral vein right next to the superficial femoral artery, which is the primary target that we're going after. So when that artery is closed, currently we kind of tunnel through the inside of that artery, and we might try to clean it out and dilate it and put some stents in there and so on, but the vessel is already dead. And so we're trying to do CPR on a vessel that has already shown itself that it doesn't want to carry blood anymore. And if you're working within those confines, there's just a tremendous amount of extrinsic compression that kind of wants to close that vessel again. And added to that is these vessels are highly inflammatory in how they respond to the trauma of treatment. So surgical bypass has been done for years. It's an open procedure. It's typically done with general anesthesia and incisions on the leg, and it's been very effective, but it's a lot to go through. And so the whole concept here was to use that femoral vein that sits right next to our vessel that's closed as a conduit. So we can basically punch from the artery into the vein, run down the vein, which is a wide open hose, re-enter the artery downstream where it reconstitutes, and then span that space with a stent graft that is capable of carrying normal amounts of blood flow to the lower extremities.
How far can you go? I know initially that we were talking just from, let's say, the proximal part of the SFA or the superficial femoral artery in the thigh to just above the knee. But when I actually had the opportunity yesterday to go and watch one of your procedures. You were sending that blood flow clear into the calf.
Yeah, correct. We originally started as going from basically the groin to just above the knee. The reality is the disease is not that discrete at all times. In fact, the patients that we really want to help go more distally. So now we've got grafts going all the way down into the small tibial vessels below the knee.
Mm-hmm. That's amazing. Well, coming up right here on the Heart of Innovation, we have some questions already coming in from our live studio audience of patients. So don't go away. You're going to hear more about this device that hijacks your vein to reroute blood flow around artery blockages in the legs. So don't go away.
Your type of condition is called critical limb ischemia. It's the most advanced form of P.A.D. or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to P.A.D. and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with P.A.D.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really really want to go through all that.
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options. We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. This is Dr. Nik Patel from Marietta and Vista, California, from AVA Vascular. I'm filling in for Dr. Phillips today, who's still out there saving some legs, working long day, long weekend. And we have a very famous host for us here, Dr. Joye, who's an inventor of a new device called P.A.D, which is a percutaneous bypass performed in patients with P.A.D and critical limb ischemia. This can be done without a scalpel, without an incision. So it's a great device. I have a couple of hands up in the audience. I have Douglas, you have a question already. If you can unmute and ask your question to Dr. Joye.
Yes, sir. Congratulations, well deserved. I watched your video twice. Now, a plumber just puts the snake in and it goes through, you know what I mean? But how nerve-wracking is it to take these such a small minute and to have to maneuver them in the places that you do place them?
Yeah, that's a great analogy. So early on in the development, that was a big challenge that we had to overcome. And the way that we simplified it is we aren't just coming through the artery heading from the top down. The other part of the procedure involves putting a little IV basically into the vein in the lower leg. So we can come up from below from the ankle. And that way we have a catheter in the artery, and we have a catheter from the opposite direction in the vein, so that once we pass our needle through the artery into the vein and pass the wire into the vein, we can basically snare that wire and pull it out the other end, and we can control it from both ends, and that allows us to navigate through the veins, the valves in the veins of the leg, and safely deliver the technology. So if it were just as you described, where we're kind of blindly going down the leg, it would be difficult to impossible. But by controlling both of the conduits, the artery and the vein at the same time, then we've been able to do this much simpler.
Do we have another question from the audience? Marsha, if you can unmute and ask your question to Dr. Joye.
Thank you very much. And congratulations, Dr. Joye.
Thank you.
I'm a fellow Ohioan, and I also attended OU.
All right.
So we have some things in common. I'm in Dayton. My question is, I have a full metal jacket in my right SFA, and that, the whole thing is re-occluded. So I have a pretty strong collateral network, which is, what how I'm getting blood flow. But at some point, this might be something that I would look at in the future. The problem is, and my question is that I was sent to a vascular surgeon who ordered a vein study, and my vein was not suitable for a bypass. So I'm wondering if you have small veins or problems with your veins. Mine was just small, I guess. And so they didn't want to use it. But so how would that play with a PTAB?
Yeah, great question. And I grew up in Delaware, not far from you. So that's a real common situation where people like yourself who might benefit from an open bypass just don't have the vein to do the job. And that leaves you with an option of a prosthetic bypass, which surgeons generally try to not do if they can help it because they're not as durable. I think the good news for you is that your collaterals are doing the job right now. So if you're able to do most of what you want to do, I would say keep walking, keep building those collaterals. When those collaterals fail, though, and you become limited and frustrated with your abilities to do what you want to do, PTAB might be an option for you. And I've treated a number of patients now who had full metal jackets, like you described, stents from top to bottom, some of whom I'm guilty of as well. But the PTAB device actually can go through the side wall of those stents and still be performed. And the vein that we use for the PTAB procedure is not the same vein that was being scanned for your bypass.
Oh.
They were looking at superficial veins that they would remove to create the bypass. This is the deep vein. This is the large vein in the center of your leg. And I have yet to see a patient that doesn't have a very robust femoral vein that can be used for this procedure.
One follow-up, thank you very much. What if at some point something would happen to my heart and they can't borrow that vein? Like, I mean, are you kind of playing Russian roulette with the bypass?
No, that's a great question, and it's a common question, and it's also I think a dated conception that is put out there by physicians sometimes. If the veins in your legs are not good enough for a bypass in your leg, why in the hell would you want to use it for your heart? All right. So thankfully, 95% of the time, we can now take care of coronary problems with stents. We don't have to rely on vein bypasses anymore. So I don't worry about, the vein that we're using for this particular procedure, again, is not harvested for bypass for the heart. And again, the heart can usually be taken care of without bypass these days.
With every one of the procedures that a patient has, we tell the patient to make sure to ask the doctor, when this fails, what is the contingency plan? What is the contingency plan when the PTAB goes down? And that compared to a general bypass going down.
Yeah, well, thankfully that's a rare occurrence, but when it does occur, the graft can be reopened with, as I mentioned, Douglas, thrombolytic, put a catheter in, drip a TPA medicine that will dissolve the blood clot, and then you maybe need to do some touch-up angioplasty. In the bigger picture, you can still do an open bypass, so it doesn't burn that bridge. Once you've done an open bypass, not too many people are excited about doing a redo. It's just a really difficult surgery. So it doesn't burn the bridge of conventional options, which is one of the other nice things about this.
And what does the data show in terms of its the patency rates? You just had 2-year data that was recently released.
Yeah, and it was there was really no fall off from 1 year, which is great. In the Detour 2 trial, the patency, we have different words we use for patency: primary patency, primary assisted, secondary, kind of the overall patency. Like at the end of the 2 years, greater than 90% of these people are open. You take the same group of people and you stuff a bunch of stents in their leg, kind of the old conventional way, 10% maybe are open, maybe 0. So that's a huge shift in outcomes.
That is
Joye,
really big.
I have a question, Dr. Joye. So when are these? When is this device going to be available where we can use it in an outpatient setting? From a financial point of view, because I think we see a lot of these patients initially nowadays with so many surgery centers, OBLs, and CLI patients getting treatment on an outpatient basis. I think this would be a great tool to have in our bag to treat these patients.
Yeah, agreed. I think that Endologics is tired of me asking that question for the same reasons. My guess is it'll probably still be another year. Most of these technologies, they need an early run of hospital-based experience and finances in order to get them down a path, and then they'll probably loosen up a little bit.
Nice.
And Marcia, you have a question for Dr. Joye?
Yes. So these are always done in the hospital. Is that what I'm understanding?
Currently.
Okay. So my original question was how long you think they last, but I think that's what you just were discussing with the patency. Is that right?
Yes, and looking back at like the early patients that I did before this was even commercially available, I've got patients that are 15 plus years.
Wow.
Wide open. So once you get past the early stage of recovery, if the doctor puts the device in properly, if the patient takes their medication properly, and if they have follow-up ultrasound testing like they should, the long term, these things should stay open for many years.
So if a patient is prone to restenosis, which I think is what I have, with scarring, like
Yep.
I'm an over scar, is this still a good option, or do you scar with this just like you would a stent?
Yeah, no, it's very different than a conventional stent, because in the stents that you have in your leg that are closed, it's a wire mesh. And so scar tissue has been able to grow through the meshwork of that stent all along the entire length of it. With this procedure, we're using a stent graft. The stent is covered with Gore-Tex so that scar tissue can't come through the side walls of the stents. It can only affect the top end and the bottom end. So when we do our follow-up, all we have to do is monitor by ultrasound how the top end and the bottom end are behaving. And as long as they're okay, then the rest of the graft is clean.
So is this widely available yet all over the United States?
It's getting more and more so. I know that they are opening new hospitals all the time. Certainly in your neck of the woods, Columbus does have it already.
And also one last question, and I'm so sorry and thankful that you're willing to answer. What is the recovery like compared to getting stents?
It's the same.
It is.
Yeah.
Okay.
So most of
Great.
our patients, even though they're done in the hospital, they go home the same day.
Wow.
Yeah.
And so
Thank
you not
you.
only have it in Columbus, but you also have it in Cleveland, right? Dr.
Right.
Sean Lyden.
Right.
Is he was part of the trial, I believe.
He was the principal investigator. Absolutely.
What about Cincinnati? I go down to the Christ Hospital. Are you familiar with that?
I'd be shocked if Christ Hospital didn't. They've been very good at adopting early technologies.
Right.
How about Denver?
Denver, absolutely. Aaron Armstrong. Yeah, Dr. Armstrong.
My question.
Yeah, Dr. Aaron Armstrong is actually his team.
Yeah.
Over there. So you named the right name when it comes to that. So Heinz is excited.
I want to ask the question to Marcia is, your stent is already occluded and you're building these collaterals. That's your natural bypass. So do you have symptoms right now, like a rest pain or claudication or anything like that? Sorry, I can't hear you. You're muted.
Sorry, I've never had rest pain and I've never had a wound, knock on wood. But I do have horrible claudication. And just in the last few days, I walk, every day. I walk a lot. But in the last few days, I've noticed my right leg is worse than my left, and it's where I have had interventions is my right leg. And I've noticed that my calf is noticeably larger on my right side. But yeah, I have claudication, and every day it's a battle. And I think I'm 65 right now. I don't know, am I going to be able to keep up with this? And as my knees and arthritis and other things happen, will I be able to keep up with it as I age? So, it's a concern, but it's nice to know there are other options maybe down the future, down the road.
I just want to I don't know if Dr. Joye had this experience with a couple of patients that I've treated with similar situation. They have an SFA occlusion, and I, go from the pedal approach to open up the SFA, but in the process, the tibial vessels are occluded, so we open that up on the way. But for some reason, we can't open up the SFA, the femoral artery that's occluded. But because these patients had a chronic occlusion for many years, they have these robust collaterals that are reconstituting, below the knee or even above the knee, the popliteal artery. And I've treated the popliteal artery and the tibial vessels, on the way trying to open up the SFA. But after I treated those vessels, somehow their rest pain goes away. and their claudication goes away because now I've treated the outflow because you have the robust collaterals already. They're acting as your bypass. And that relieves their symptoms and they tend to do better. I have a 1-year follow-up on one of these patients and he's like, I'm doing great. I'm walking like you told me to, and I'm not getting any claudications. And his SFA is still blocked.
I'm confused. So now that I have re-occluded, you're saying that a possibility would be treating the tibials?
Yeah, so treating the outflow because you have all these collaterals that I've already built, over many years. And where these collaterals connect to the artery that's open, that artery may be a little diseased or narrowed. And if you just treat that, open that up, you're getting more blood flow now, and that could be enough to relieve your symptoms, So
yeah, that's kind of next level thinking, which not surprising from you, Dr. Patel. But yeah, people that have a good collateral source from their profunda, from their deep femoral artery, and have an SFA occlusion that for whatever reasons is impassable, previous to a technology like the one we've been talking about, one option, and I've done the same thing, if they have impaired tibial artery flow, is to treat the tibials from a retrograde approach from the ankle heading north. And if you open those tibials, then they can obviously carry more blood flow to the calf on the foot. And that definitely helps people. But, bigger picture now is, those previously impassable lesions, those long occlusions that have been there for a long, long time, we can definitely reroute around them.
Right.
Thank you. Gives me something to think about.
Keep walking, Marcia.
Thank you. I'm trying.
I know. I appreciate
walking and hydration. 2 miles of walking, 2 liters of water.
Well, I don't have enough water. I'm sure of that. But I do the 2 miles easy.
Yeah,
Not easy, but I do it.
Dr. Joye, can I ask you one question real quick? I appreciate your time on this. So a lot of patients have problems with SFA because of various reasons. I'm one that has radiation-induced peripheral artery disease in my leg. So, and Dr. Aaron is my doctor currently, and they've helped me out. Would your procedure work with something like that, with the vein and artery being somewhat more contaminated?
Yeah, individuals like yourself who have radiation-induced artery narrowing tend to be the ones that re-narrow the most. So if we're trying to fix the artery from the inside, it's really, really difficult. So these are great situations to actually bypass around it. Just that artery is not going to, they typically have a hard time staying open because they have just continued low-grade inflammation from the prior radiation. So yeah, no, it'd definitely be a possibility.
So that your new device would be a possibility, basically.
Yeah, well, it depends on where your blockages are located, but if it's superficial femoral, absolutely.
Pop and superficial femoral.
Yeah, for sure.
Cool. Thank you.
Sounds like you have a conversation with Dr. Aaron Armstrong.
Yeah, I'm getting re-occluded, so yeah, okay.
Well, coming up right here on the Heart of Innovation, we're going to have more with Dr. Jim Joye. We're going to hear some of the resistance that he's faced in bringing this to market. Up next, right here on the Heart of Innovation and KDOW. Don't go away.
When you are walking and you start feeling that pain and cramping, it's the conversion over from oxygen producing energy to it's called anaerobic metabolism. So you're going from aerobic metabolism, which requires oxygen to produce the energy for the muscles, to now you're using anaerobic, meaning without oxygen, which the byproduct of that is actually lactic acid. And so that's why you're getting the cramping in that claudication. When you start walking further, you've used all the oxygen in the tissues. And so now your muscles, in order to function, are converted over to a non-oxygen energy producing state. And the byproduct of that is lactic acid, which causes the cramping and pain. And so when you are walking and you start feeling that pain and cramping, and then you try to walk a little bit further, now you're training your muscles, and you do this repetitively over and over. You're doing it every day. while you're slowly building up, that's how you're able to walk further and further, because your muscles are able to use what oxygen can be delivered more efficiently. Just like a marathon runner, learns how to use oxygen more efficiently, that's what you're training your muscles and then your blood vessels, all the tissue around it, is that walking actually causes this low oxygen tension situation, and you repeat it over and over and over again, and it becomes where now you can walk without pain. And that's because your muscles and your tissues are used to this lower state of oxygen level, and they're used to learning how to use it more efficiently.
For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. This is Dr. Nik Patel filling in for Dr. Phillips. We have a very important, famous guest with us today, Dr. Joye. And we were just going through some questions asked by Marcia about whether we can use the veins, that are used for bypasses. Would that be a contraindication for this procedure? And Dr. Joye explained that these are different veins. These are deeper veins compared to the superficial veins. And long as your deep veins are open, meaning there's no blood clots, I think you would be a candidate for these procedures. Dr. Joye, would you want to expand on that? Patients with DVT, would they be a candidate for this procedure?
Yeah, that's in the trial that led to the approval of the procedure. Patients with prior DVT were excluded, and that makes sense when you're in clinical trial mode. In the real world, case by case, I think you have to make decisions that are best for each patient. And so many people who have a history of DVT or a blood clot in the leg, which can affect the femoral vein, will recanalize, meaning that the blood clot will dissolve, and then you have a highway that you can utilize for this procedure. And so for those patients, as long as their limb is not massively swollen as a result of damage from the DVT, they certainly can be candidates. One of the first procedures that I did after this was commercially released was a local farmer who was just unable to maintain his farm because he was so limited in his walking ability. He had had a previous DVT. His right femoral vein was completely closed. And at the same time, he had complete closure of his superficial femoral and popliteal arteries. So he was kind of a double whammy, where he had a swollen leg and he couldn't walk very far, and he was just frustrated, 73, 72-year-old guy. And after evaluating him, we found that, this was kind of a way to, expand our offerings. I was able to travel through a venous collateral, which was well-developed and went around the DVT and arrive at the same destination that we needed to, that allowed us to perform the bypass, restore the arterial blood flow. His femoral vein was already closed. He had other collaterals that were healthy. And so borrowing that one collateral allowed us to do the procedure and still not impact his venous health as well.
So I'm curious some of the resistance that you may have faced. We had world-renowned interventional cardiologist that you know well, one of your buddies, Dr. Craig Walker, on recently. You said, today with all the minimally invasive tools and techniques, there's probably not a blockage that you can't really get through these days with some of the more advanced tools and techniques that are available, number one. But then you have vascular surgeons, on the other hand, that say, well, why is this type of percutaneous bypass needed, the minimally invasive bypass needed, when we could just do a regular bypass? What do you have to say to some of those additional healthy doses of skepticism for the PTAB?
Yeah, so I mean, some degree of cross-discipline friction is good, kind of keep each other in check. But as is the case with any new technology, there are, some people just have a knee-jerk reaction that they're reluctant to change, especially if they've been doing it a certain way for 20, 30 years, and they know how to do only that one thing. There's a lot of, in this business, there's a lot of, if I can't do it, it can't be done, that we hear. So resistance is not unusual. I mean, we faced the same resistance when we started to do aortic valve replacements through a catheter, when we started to do aneurysm repairs through a catheter. You know, early on, resistance. They don't want to give up the golden goose. They don't believe the data. They haven't done it themselves. They have to do their own personal trial to see if it's going to work. You know, some of the more valid pushback or questions, I mean, the first thing that they think about is, well, how can you possibly put a stent graft inside this femoral vein? The patients are all going to have DVTs and blood clots in their lungs, and they're going to die. And that's hysteria, and it's wrong. In the clinical trials that was done, we had 0 PEs. We had classified as 1% of the cases out of 200 and some cases had a, quote, clot in their leg. And that fear has been debunked. Then you get to, well, how can this possibly work as good as a bypass? Well, I would argue that it works far better than a bypass, because we don't have to interrupt the skin. We don't cut the skin. We don't introduce open wounds for infection. We don't interrupt the lymph system to create lymphoceles. And we don't have to sew the graft onto the artery, which creates inflammation. The graft is simply placed in there and gently dilated and immediately starts to work. So there's always going to be pushback and criticism, and you know, part of the job in bringing stuff to market is you've got to have some pretty thick skin. I've lectured to crowds of vascular surgeons, you know, the old guard, and they were just lined up in the front row waiting for the Q&A part so that they could start launching the missiles. But you know, if you just have a civil conversation and you talk through the physiology and the anatomy and the reality of the data is unbelievable.
There. Yeah. And, you know, before we go to break, I just wanted to, we do have a very special caller that just wants to sing your praises. It's someone who's very special to me as well, who's decided to call in. My dad, whom you've saved multiple times. He just wanted to give you a shout out. Dad, go ahead and jump in. Dr. Joye is on the line here.
Good morning, Dr. Joye.
Good morning.
Good morning. Good morning. Between my daughter and you, I guess I'm standing here. Somehow.
More so her.
Anyhow, what the first one was that I had another source did an ultrasound on me and found clots in the femoral veins and said they were occult and was going to get Eliquis to me in a couple of days from a pharmacy. And she immediately called you and you said, basically have my butt in there the next morning. And you did your ultrasound. And on the next morning, bright and early, you were putting a filter in. And thank God you put the filter in. As you told me, or Dima told me, that when they took the filter out, that I'd either be dead, heart attack, or stroke. So I owe that to you and Kym. And within a month, because I'd had shortness of breath for, God, almost 10 months and the Thursday before she called you, I couldn't walk up 3 stairs. And she's getting ready to take me to the emergency room on Sunday. And she picked the phone up and called you. And you said, get his butt in here first thing in the morning. And on Tuesday morning, you had me in surgery and found out I had 2 blood clots completely sealed in the subarteries of the RCA. So that's the second time around. And when I come out of the anesthesia, I was breathing, no shortness of breath. And I just want to say thank you. And we'll see you next Wednesday for venal ablation.
Yep.
All right. You're very welcome.
Mm-hmm. Yeah. Thank you from the bottom of my heart for having, you know, my dad here and being able to save his life, save his limbs. So he wanted to make sure he heard you were coming on today, and he wanted everyone to know that you are his hero and also my hero as well. So we really, really appreciate you so much.
We have to go to break, and we will learn more about the struggles doctors face in treating blocked arteries in the leg. And also, Kym and Dr. Patel will continue their conversation with interventional cardiologist and limb-saving device inventor, Dr. Jim Joye, in just a moment. Please do not go anywhere. We will be right back here on AM 1220 KDOW.
For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. We only have a couple more minutes here. We're talking to Dr. Jim Joye at Golden State Heart and Vascular in the San Francisco Bay Area, and we're talking about this now FDA-approved device to provide a minimally invasive bypass procedure whereby a doctor can hijack a vein in the leg to reroute blood flow around a blockage in a leg artery. And Dr. Joye, I'm curious, this is something, once you get the FDA approval, you're always learning and growing. And yesterday when I was in a procedure, you actually learned something new that you had never done before. Would you mind talking about how you can now use this device differently than you may have thought?
Yeah, absolutely. It's true of any new technology. When you kind of get unshackled from the limitations of a very rigid clinical trial and you start to practice real world medicine, then you start to really understand what the true potential might be. And the case in question from yesterday was a patient who had had a prior bypass surgery that had failed, had prior stents in the leg that had failed, and was unable to sleep through the night because her leg would wake her up in the middle of the night. She'd have to get up and dangle just to wake the leg up. So when we started her procedure, my intent was to go into the native artery, into the old stents, and to use that as our launch pad to do the procedure. As it turns out, the wire and catheter chose to go into the old bypass instead. And we hadn't done this before, but it was like, well, the bypass and the artery are both right next to the vein. Why not just use that as a starting point? And we did successfully. But one thing we know about bypass grafts that have been closed is they're basically full of clot, or something similar to it. And so in the course of doing the procedure, there's a lot of in and out, transitioning of catheters. Some of that clot got liberated. After we had completed a perfect bypass, some of that clot went downstream, and then we had to use some of the techniques we use routinely to remove the clot, restore the flow. And, in the end, everything was perfect. But, a little curveball along the way that going forward, I'll be able to advise people that we train in this device, hey, if you decide to do this, watch out for this.
Well, I see that you're inventing new techniques as your device is getting implemented in the clinical space. Have you thought about any other ways to use this device in a different way, in a setting where we can actually go down and treat the tibial vessels in these patients with diabetes, because that's where a majority of their disease is?
Yeah.
I'm sure you must have a thought and idea about the next step in innovating this device into different use.
Yeah, I mean, for me right now, that's kind of the fun part, is exploring what its full capacity might be. I remember giving a lecture at a meeting once, and one of my friends, a great vascular surgeon, John Matsumura, came up to me afterwards and he said, "Keep going." He said, "Keep going." And what his message was don't stop with the FemPop, explore further. And so, yes, I do believe that this is, we're already using this to bypass into the proximal tibial arteries. With smaller grafts, with different tooling, we will be able to attack those below knee targets on a regular basis. And heading the other direction, up towards the aortoiliac space, that may be a possibility someday as well.
When is this device going to be available where we can use it in an outpatient setting, from a financial point of view? Because I think we see a lot of these patients initially nowadays with so many surgery centers, OBLs, and CLI patients getting treatment on an outpatient basis. I think this would be a great tool to have in our bag to treat these patients.
Yeah, agreed. I think that Endologics is tired of me asking that question for the same reasons. My guess is it'll probably still be another year. Most of these technologies, they need an early run of hospital-based experience and finances in order to get them down a path, and then they'll probably loosen up a little bit.
Nice.
Fantastic. Thank you so much, Dr. James Joye with the Golden State Heart and Vascular. We really appreciate you being here. Congratulations on the Global P.A.D. Association's 2024 Global P.A.D. Impact Award, champion of Vascular Innovation for 2024. We really appreciate you being here. Thank you for all you do to save life and limb.
Thank you, Kym. Same to you.